digest a big blob lipid. Okay, sorry. Okay, so I was basically telling you that lipids like to aggregate together to form a big droplet. If they form a big droplet, it's really difficult for you to digest it. So for example, in the small intestine, suppose that lipid goes up back together into a big droplet, the surface area for digestion is very low and absorption. Okay, so it's very difficult to digest lipids. So what you need is you need to first you firstly need to break that lipid up into small droplets, and then you need to prevent those small droplets from coming back together. This is the function of bile, okay? So the stomach, when it contracts, it breaks up lipids into small droplets. Those small droplets go into the small intestine. The bile will come into the small intestine and surround those small droplets of lipids. And this will prevent those small droplets from coming back together. This process is known as emulsification. Okay, so emulsification is you preventing the recollection of lipids into a big droplet. And now, because those lipids are in small droplets, they're easy to digest. And so emulsification increases the surface area for digestion. So that's one function of bile you need to know, okay? So bile is responsible for emulsification of lipids, which is increases surface area for digestion and absorption. The second function is once that lipid has been digested, that bile surrounding it plus the digested lipid is called a micelle, okay? So a micelle is basically bile surrounding the digested lipid. That micelle is basically like a taxi. It takes that lipid digested lipid product to the small intestinal cell from where it gets absorbed. So those are the two functions of bile you need to know. Number one, emulsification, which increases surface area for digestion. Second one is micelle formation, which basically allows for digestion of the lipid products, okay? So this is a general summary of what we're going to do today. So again, bile is produced, number one, by the liver by hepatocytes. It's made from cholesterol. You need to know that. Bile is made by hepatocytes from cholesterol. It's secreted into bile ducts, which are lined by cholangiocytes. Okay, so you have cells here, different sorts of cells. These are called cholangiocytes. They basically secrete two things. Number one is water. The important thing is bicarbonate, okay? Okay, so cholangiocytes secrete bicarbonate, which is very, very important. And you need to know that bicarbonate is stimulated by a hormone called secretin. And this is very easy to understand, okay? So secretin, okay. So you can think of secretin as like a negative feedback loop. I'm explaining this, these are just general concepts. We're going to repeat them so many times later on. So it'll be easier for you guys to understand. But for now, you just know that secretin is a negative feedback loop. Do you guys know what cells release secretin? Does anyone know?
S cells.
S cells. And in response to what?
Acid.
Acid, yeah. So secretin, you can basically think of as a negative feedback loop. You remember your process of homeostasis. So this is essentially like homeostasis. Acid comes into the duodenum and stimulates S cells to release secretin. Once secretin has been released, it needs to neutralize the acid. So what it does is it stimulates bicarbonate secretion from the bile duct, from cholangiocytes here. And second, it stimulates bicarb secretion from the pancreas as well. When you have bicarb in the duodenum pH will go up because that acid is neutralized, and this will inhibit secretin secretion. So it's just a negative feedback loop. Acid stimulates secretin, secretin stimulates bicarb, bicarb neutralizes the acid, neutralization of the acid decreases secretin. So you need to know this process. This is important for you to know. It comes up in our exams as well, in GI exam and in USMLE. Second thing, what happens is that bile now has been released from the bile ducts. It goes into the gallbladder. The gallbladder has three functions. Number one, storage of bile. Number two, concentration of bile. So bile basically contains bile salts, one. Number two, phospholipids. Number three, cholesterol. And number four, bile pigments, which is bilirubin. You need to know that. Okay, so these four products are bile. Bile salts, cholesterol, phospholipid, and bilirubin, which is bile pigment. And bilirubin is yellow. Okay, so that means bile is yellow. What happens is all of those four components go into the gallbladder here. The gallbladder absorbs water, but it doesn't absorb the bile. If it absorbs water, but it doesn't absorb the bile, the concentration of bile increases. So gallbladder is responsible for concentration of bile. Now, what happens when you eat a meal, when those fatty acids go into the duodenum, they stimulate things called eye cells. Eye cells release CCK. CCK is basically responsible for lipid digestion. You can think of it as a negative feedback loop. So fatty acids, fat enters the small intestine. You need to digest those fats, so you release CCK. CCK stimulates bile acid gallbladder contraction, which releases the bile into the small intestine, allowing you to digest the lipids. Okay, so these are two negative feedback loops you need to know. Number one is secretin, which is acid. Number two is CCK, which is responsible for fat digestion. So this was a general overview of the whole lecture. We're going to go in detail now. So we're going to go first bile acid production, then what the duct cells do, cholangiocytes, then what the gallbladder does, and then we'll talk about gallstones. Again, bile acid is secreted from, let me use laser. So bile is secreted by hepatocytes. It's modified by the duct cells, by cholangiocytes, which add bicarb. I told you this is caused by secretin secretion, which is basically like a negative feedback loop. Number three is stored and concentrated in the gallbladder, which absorbs water. Wherever sodium goes, water goes, right? So it absorbs sodium and chloride, and water goes with it, but it doesn't absorb the bile. So bile gets concentrated. Number four is discharged into the duodenum. Basically, when you have food in the duodenum, you release CCK. CCK causes gallbladder contraction and relaxation of the sphincter of Oddi, which causes bile release into the small intestine. These are four processes. We'll look at each one. Bile, as I told you again, is responsible for two things. Number one, emulsification of the lipids. Basically, it prevents those small droplets from coming back together, which increases surface area for digestion. Okay. Someone asked me, is there any vagovagal reflex? We'll discuss that later on. I was just giving an overview. We'll discuss more specific things as we go along, okay? Bile acid, so bile acids have basically two functions: emulsification, which increases surface area for digestion, then solubilization of the end products of lipid digestion, which is basically micelles. Okay, so this is emulsification, solubilization is by micelles. Bicarb aids neutralization of the acidic gastric chyme, and this is promoted by secretin release, which is basically like a negative feedback loop. Now, this is basically summarizing the four components of bile I told you. Number one, bile acids. Number two, phospholipids. Number three, cholesterol. Number four, bilirubin, which is the bile pigment, which is yellow. You need to know these four things because we'll come back to this when you talk about jaundice, okay? So bile acids, phospholipids, cholesterol, and bilirubin. Other components includes electrolytes and water, okay? Now, this is very important now. I told you that bile acids are synthesized from cholesterol. You need to know that once cholesterol comes into the hepatocyte, sorry? Okay, no problem. You need to know that once cholesterol comes into the hepatocytes, there's an enzyme called 7-alpha hydroxylase. You need to know this enzyme. This is the rate limiting step of bile synthesis, okay? Cholesterol comes into the hepatocyte, 7-alpha hydroxylase produces cholic acid and chenodeoxycholic acid. Now, what you're trying to do basically is, because I told you cholesterol is a lipid, right? And we need to make bile soluble. And so bile acids are basically a soluble version of cholesterol. So you can think of bile acid synthesis as basically making cholesterol more soluble. Okay, so the first thing that happens is you hydroxylate cholesterol to form cholic acid, chenodeoxycholic acid. This is the rate limiting step of bile acid synthesis. Another name for the rate limiting step is regulator step, okay? How is this regulated? By negative feedback again. Once you have a lot of bile acids, you don't need production of bile, so you inhibit this enzyme. If you don't have bile acids, then this enzyme will work more to produce bile acids. So this is a negative feedback you need to know. So again, two things you need to know. First step is 7-alpha hydroxylase. This is also the rate limiting step of bile acid synthesis. And as a general concept, this is to increase water solubility. Okay, so now the first step was basically hydroxylation. Second step is conjugation. You conjugate bile with glycine and taurine, okay? Glycine and taurine basically make bile acid more soluble. Again, the whole process is basically trying to make cholesterol more soluble. And this is important because conjugation decreases pKa. Do you guys know what pKa is? Does anyone know what pKa means?
Dissociation factor.
Okay. So in simpler words, pKa of a molecule or of a substance is basically the pH at which, how do you say? pKa is basically the pH that that substance wants, okay? So for example, unconjugated bile has a pKa of 5. That means unconjugated bile wants a pH of 5. So let me draw an equation for you here. HA, which is an acid, goes to H plus A minus, okay? Let's say the pKa of this equation is 5. We're talking about unconjugated bile acids. The duodenal pH is 4, which means that the duodenal pH is lower than the pKa, which means that the pH is more acidic than the unconjugated bile acids want it to be, okay? So that means there's more hydrogen. Yeah, I'll repeat, no problem. But let me just complete this one thing and then I'll repeat myself. If the pK, in a general way, if pH is less than pKa, that means the solution is more acidic. If the solution is more acidic, that means there's more hydrogen. If there's more hydrogen, the reaction will move this way to produce HA. This, as you see, there's no charge here. It's not ionized. If it's not ionized, it's less water soluble. And if you remember, the whole point of bile acid synthesis was to make it more soluble. And so you don't want it to be insoluble. So what we do is we conjugate bile with glycine or taurine to decrease pKa, which makes them more soluble. And I'll repeat this one more time. So unconjugated bile, which is cholic acid and chenodeoxycholic acid without glycine and taurine, their pKa is high. If their pKa is high, that means that they are in the non-ionized form within the duodenum. Unconjugated bile acids are non-ionized in the duodenum, which means they're less water soluble. And that's not good. You need bile to be water soluble. So what you do is you conjugate or you add glycine and taurine to cholic acid and chenodeoxycholic acid to basically decrease their pKa. Now, if pKa is decreased, then that means that there will be more of this form, of the ionized form. Now that it's ionized, it's charged, it's more water soluble, which is good. So unconjugated bile acids are in the unionized form in the bile. This is what you need to know only. If pKa, pH, that's more biochemistry. You don't need to know that. If you understand it, it's good. But what you need to know, unconjugated bile acids have a high pKa. Because of that high pKa, they're in an unionized form in the duodenum. Because they're in an unionized form in the duodenum, they are lipid soluble or unionized or water insoluble. The point of conjugation is to decrease pKa, which makes them more ionized. And so conjugated bile acids are more ionized, so they're more water soluble. Does everyone understand this concept? Make sense? Simple? Okay. I got a message, cholic acid has a high pKa than glycolic acid. Yes, essentially, yeah, amina, yeah. So cholic acid would have a pKa of 5, which would make it unionized. Glycolic acid, i.e. cholic acid plus glycine, has a pKa of 3.8, which is lower, which basically means you've got more of this form. If you have more of this form, that means it's ionized. If it's ionized, that means it's water soluble. If it's water soluble, if you remember the big picture image we were talking about, if you remember this big picture image we were talking about, the function of bile is to basically solubilize the lipids. How does it do that? Because it's amphipathic. So you have a water soluble portion pointing outwards. You have a lipid soluble portion pointing inwards. The lipid soluble portion dissolves the fat in your diet. The water soluble portion is responsible for preventing their collection again. So emulsification. So the water, you need it to be water soluble. Now, can you repeat it briefly? Yeah, so you just need to know 3 points. Number 1, okay, let's take it from here again. You have cholesterol. First step is 7-alpha hydroxylation. This produces cholic acid and chenodeoxycholic acid. You need to know that this is the rate limiting step and it's regulated by bile. So if you have more bile, you will have less 7-alpha hydroxylase. If you have less bile, you will have more 7-alpha hydroxylase activity. So first step is hydroxylation. I think this is clear. Second step is conjugation. Why do you need to conjugate? Because unconjugated bile acids have a high pKa, which means they're unionized. You need to conjugate them with glycine or taurine to decrease their pKa to ionize them. If you ionize them, you make them more water soluble. I hope now it's clear. Okay. This now we discussed hydroxylation, conjugation. Now suppose bile acids are produced. Let's go back to the image first. Let's go back to this one. Okay. So you produce cholic acid and chenodeoxycholic acid, all of that was happening in the liver, right? Okay. So all of that bile acid synthesis that we discussed is happening here. Hydroxylation, conjugation, secretion into the bile ducts. Now, let's say you have chenodeoxycholic acid and all those unconjugated bile acids here. Eventually, they would get reabsorbed back into the liver. Okay, so that's the slide we're going to discuss now. This bile acids or bile salts are reabsorbed in the ileum. You need to know that. Firstly, that bile salts are reabsorbed in the ileum. They're reabsorbed to decrease the demand of the liver to synthesize more acids. So for example, let me give you an example. You synthesize let's say you have 2.5 grams of bile in your body. If you have 2.5 grams of bile in your body and you secrete all of that bile into the intestine, okay, now the liver needs to make all of those 2.5 grams of bile again. And that's a lot of work, okay? So you don't need that. So what you do is you reabsorb like 95% of that back into the liver in the ileum. Again, know the ileum. So this is called entero means intestine, hepatic, liver, enterohepatic circulation, okay? Or enteroportal circulation. This is basically reduces the workload for the liver. Okay. This is where we were. So you have glycolic acid and taurocholic acid. These are basically those conjugated bile acids we were talking about. They get unconjugated and dehydroxylated. Remember, the first step of bile acid synthesis was hydroxylation. Second step was conjugation. In the ileum, you get dehydroxylation and deconjugation. So you're basically removing all of what you added into cholesterol. If you remove all of that, now the remaining is called a secondary bile acid. that secondary bile acid is more lipid soluble. These secondary bile acids, like here, like deoxycholic acid and lithocholic acid, they get absorbed by the ileum, get transported back into the liver. Some of that bile is lost in stool, but not most of it. 95% you actually absorb back into the liver. And again, this reduces the workload for the liver. So I hope this step now makes sense as well. Make sense, everything? Or should I repeat this
So
step?
just one quick thing, right?
Okay.
So cholic acid, it's biocholesterol after getting all the hydroxylation stuff going on it, and then becomes glycolic acid. After it's done doing its job, it goes back to the ileum, right? To go back to the liver. So after the conjugation, the hydroxylation becomes deoxycholic acid and lithocholic acid.
Yep. And deoxycholic acid, so just to link it with what we were talking about earlier, deoxycholic acid, because it has no hydroxyl group and because it's not conjugated, is more lipid soluble than glycolic acid. Make sense?
Yes.
Okay. Anything that enters the liver should be deconjugated and dehydroxylated. It depends. We'll discuss it later on that some of the bile you reabsorbed is still conjugated. So not necessarily, but for the purposes of this slide, you need just you need to know that. Okay. Conjugation and dehydroxylation, I don't understand. Okay. So bile acid synthesis, we said was two steps. Number one, hydroxylation. Number two, conjugation. The aim of these two steps was to make bile more water soluble. Now, in the ileum, now bile has done its job, okay? You're in the ileum, in the last part of the small intestine. In the last part of the small intestine, you have bacteria. Like normally you have bacteria in the colon, but some of them are in the ileum, okay? They deconjugate and dehydroxylate those bile acids. So they form secondary bile acids. These secondary bile acids are reabsorbed into the liver. When they're reabsorbed into the liver, this reduces the workload for the liver. So instead of producing 2.5 grams of bile every day, it only needs to produce around 600 milligrams of bile. So it reduces the workload for the liver. And you need to know this because, for example, there are some people who have, and this is a clinical scenario, for example, there's a guy who has an intestinal disease and they needed to remove his ileum. If they needed to remove his ileum, now he can't reabsorb those bile acids anymore. And so his liver has to work a lot now. It has to produce 2.5 grams daily of bile. Eventually, the liver won't be able to keep up this high workload and bile acid production will go down. When bile acid production goes down, now you don't have enough bile to digest lipids. If you don't have enough bile to digest lipids, you will have lipid malabsorption, which will give rise to steatorrhea. Okay, so there's a clinical scenario later on in the presentation, in something like this. So the purpose of formation of secondary bile acids is for enterohepatic circulation. Yes, exactly. Malabsorption. Malabsorption basically means you're not able to absorb it. The word mal essentially means non-functional or impaired or diseased. So absorption is not normal, it's diseased. So lipid malabsorption, you're not able to absorb lipids. Protein malabsorption, you're not able to absorb proteins. Okay. So I hope this is clear now. Hydroxylation, conjugation, these two produce primary bile acids. In the ileum, bacteria deconjugate, dehydroxylate to produce secondary bile acids. Secondary bile acids are put back into the liver, and this is like 95% of the bile you produce. This reduces the workload for the liver. That's what you need to know. Okay. Now, we said bile has two functions, right? We said number one was emulsification, which is basically to prevent those small lipid droplets from coming back together. The second function we said is solubilization, and the bile plus the lipid products of digestion, they are known as micelles. Now, a lot of people get confused with this critical micellar concentration. What this basically means is the amount of bile necessary for you to produce micelles. Does that make sense? I'll repeat it one more time. The critical micellar concentration is the amount of bile required for you to produce micelles. Okay? If bile concentration drops below the CMC, you won't produce micelles. So in the guy, for example, when we were discussing who had his ileum removed, his bile acid production will go down. Eventually, the concentration of bile is not enough to produce micelles. Yes, CMC basically means critical micellar concentration. Critical micellar concentration, or CMC, is the same thing. So critical micellar concentration, again, is the concentration at which bile produces micelles. If for any disease, like for example, your liver is not working properly, or your ileum has been removed, or for example, you have a gallstone which is obstructing the delivery of bile, the bile concentration in the intestine will not be enough to form micelles. So they will be below the CMC. And so what makes up a micelle again? A micelle is basically bile plus the digested products of the lipid. So the first function of bile was emulsification, right? So this was to increase surface area for digestion. So the pancreatic lipase comes in, it digests those dietary lipids that you've ingested. Once those lipids have been digested, the bile surrounds them. So the bile plus those digested products equals micelles. Okay? So lipids are digested by bile? No, lipids are not digested by bile. Lipids are emulsified by bile to increase their surface area for digestion. Lipids are digested by the pancreas. Pancreas release lipase. But because, again, the big example I gave at the beginning was that lipid likes to come back together to form big droplets. And it's very difficult for you to digest such a big droplet. So what the bile comes in and does is that it breaks up that big droplet into small pieces. Now those small pieces are easier to digest for the pancreas, not by the bile. When the pancreatic lipase comes in and digests those small pieces, the bile surrounds those small pieces to form micelles. Now those micelles are basically taxis. They go from the lumen or from the duodenum to the lining, to the cells, and deliver the lipid. And from there it gets absorbed. I hope this makes sense. Okay, somewhat. Okay. Any questions? One guy understands. So micelles are transporters. Micelles are not transporters. Well, they're not cellular. If by transporter you mean in the cell membrane, they're not transporters, but they are transporters in the sense that they just carry the lipid from the lumen to the wall, to the cells. Okay, so they're like taxis basically. So what's the function of micelles? Okay, let me just give you an example here. I'm trying to Okay. So let's say you have a lipid here. Lipids, the problem with lipids is that they're just too big to digest. Okay, you can't digest this because it's just too big. The surface area is very low. What bile comes in and does, this is bile, that it breaks up this big lipid into small pieces. Okay, listen carefully, this is important then. Okay, these lipids are too big to digest. Bile comes in and it breaks up these lipids into small pieces. This is called emulsification. Okay, we're not talking about micelles here. This is emulsification. The bile will surround these lipids and prevent them from coming back together. Now this big blob of lipid is now broken up into small pieces, which means it's easy to digest. The pancreatic lipase comes in and digests this lipid. Now, suppose these little circles are digested lipids, okay? Bile will come in and surround these lipids like this, like this, like this, and like this, okay? So the inside circle is the digested lipid, the outside circle is bile. This whole complex, one is called a micelle. This micelle basically transports this digested lipid to the cell. Suppose, let's say this was the lining of the intestine. You have a lot of digested lipid here, but you need to get this digested lipid to the wall for it to get absorbed, right? Because the enterocytes are here. These are the cells of the intestine. They need to absorb the lipid. The micelles basically carry this lipid to the wall of the intestine. So they're like taxis. They carry the digested lipid to the wall of the intestine. Does this make sense?
Yes.
Okay. Got it. Yes, finally, alhamdulillah. So what's the role of pancreatic lipase after emulsification? Pancreatic lipase is an enzyme that digests the lipids. So we're going to get into biochemistry here. I don't want to get into biochemistry, but just you eat lipids in the form of triglycerides, okay? You digest them into fatty acids. The enzyme that does this is called lipase. That's it. That's the function of pancreatic lipase. It basically digests the lipid. I mean, before the bile surrounds the lipid droplets or after? After, yeah. So bile will, so let's say you have this big droplet of lipid in the stomach. The stomach contracts, it pushes this big droplet into the duodenum. This mechanical contraction of the stomach sort of breaks apart this big droplet into small pieces. If you didn't do anything, those small pieces would come back together because it's hydrophobic to form this big droplet again. Bile just comes in and surrounds those small droplets to prevent them from coming back together. This is called emulsification, okay? This basically makes it easier for pancreatic lipase to digest the lipid. Once pancreatic lipase has digested the lipid, now you have micelles. Micelles carry those digested lipids to the intestinal cell for absorption. Okay. So I hope all of it's clear now. Okay. This is basically showing, it's not that high yield a slide, to be honest. You did this more in histology. Basically, between two hepatocytes, there's a canal, right? Let me get, yeah, okay. Between two hepatocytes, there are canaliculi, and into that canaliculi, you're secreting the bile. In the next slide, the professor will magnify this image, right? So all of that conjugation, hydroxylation is happening in the hepatocyte. Those primary bile acids are then secreted into the canaliculi. From the canaliculi, they're going into the common bile duct and all of that, eventually into the gallbladder. What's the meaning of increasing surface area for digestion? Does it mean that the duodenum gets dilated? Increasing surface area, okay. Let me give you an example. If you're trying to digest something, let's say, but it's this big, is it easy to digest or difficult to digest? It's difficult to digest. But if you break up that big droplet into small pieces, It's easy to break down. This basically means increasing surface area. It's a bit of fancy language. You don't need to worry about that. You just need to know that it breaks up a big droplet into smaller droplets, which are easier to digest. Okay. Now, again, this is basically the canaliculi. This is that slide is basically showing the same image but magnified. Okay, so this is the hepatocyte. This is the canaliculi. Again, this is the hepatocyte. This is the canaliculi. This slide, I know some people get confused in GI because of like transporters and stuff. You don't need to know much from this slide. You need to know that bile acid secretion is an example of active transport. It came in our exam, I remember, that which one of the following is an example of primary active transport? The answer was bile. Okay, and you need to know that the protein responsible or the pump responsible for bile acid secretion is called bile salt export protein, BSAP, and this again is ATP dependent. You need to know this step. Other steps, if you remember, is good. Is if you don't remember, is whatever. But you need to know that bile acid secretion into the canaliculi is an example of active transport. Active transport meaning it utilizes ATP. Other steps, I'll go through them. But for let's say, for example, you remember that enterohepatic circulation we were talking about. So those bile acids are coming back into the liver through here. I think someone asked me whether those bile acids need to be conjugated or unconjugated. Those bile acids can be conjugated. If they're conjugated, they'll get absorbed by co-transport with sodium. If they're unconjugated, they get absorbed by anion exchange. Okay. Eventually, those unconjugated ones would be conjugated again. By conjugated, I mean, again, recall that conjugation is basically with glycine and taurine. It is to decrease pKa of the bile acid to make it more soluble in the duodenum. So from this slide, again, the one thing you have to know, bile acid secretion into the canaliculi is ATP dependent. The protein is called bile salt export protein. Other steps, you know them, you don't know them, it doesn't make a difference. Okay. In general, should I remember every step of physiology? No. You're not a physiologist, you're becoming a doctor, right? So you just need to know the important steps. As a general advice, remember the steps which have regulation in them. So the reason I'm emphasizing on bile salt export protein is because it's regulated. We'll discuss this later, but it's regulated. The other ones is it's just basic physio. You don't need to remember that much because it's not going to help you as a doctor. Like how is knowing that bile acids are co-transported with sodium going to help you in a clinic? It's not so. So just remember these one step. Remember the important steps. Okay, again, this slide useless. Okay, so now we've done bile acid synthesis. Bile acid synthesis took place in the liver. Initial step was hydroxylation, 7-alpha hydroxylase. Second step was conjugation with glycine taurine. Third step was secretion into the canaliculi, which was ATP dependent. You need to know that via bile salt export protein, BSEP. Now we're moving down, okay? So we've done synthesis, now we're moving on to transport. Now that bile is going along the ducts of the bile ducts, and those cells lining the bile ducts are called cholangiocytes. If you remember from this image, we said that in the duct, you basically secrete ions and water, and this is stimulated by secretin. You need to know that. Okay. Now, ductal flow of bile acid secretion. Again, one way is to remember everything, but again, it's just too mashwar, so don't concentrate much on that. What you need to know is, again, big picture, duct secretes ions and water into the bile. How does it do this? There's two things you need to know. There's a surface, so this is the lumen of the duct. Okay, this is the duct. This is the lining of the bile. So this is the wall of the bile duct. This is the cell. This is the lumen of the duct. On the lumen of the duct, there's a protein called CFTR. This secretes chloride into the lumen. Once chloride gets secreted into the lumen, it gets exchanged for bicarbonate. You need to know these two steps. Chloride is secreted into the lumen via CFTR. Chloride is reabsorbed by an anion exchange in exchange for bicarbonate. If you have more bicarbonate in the lumen, it means that the lumen, you mean blood vessel? No, lumen basically means, let me just, this is just a bit of terminology you guys should be aware of. So let's say this. Suppose this is a duct, right? This is a blood vessel, this is a pipe, this is a bile duct, it's whatever, it's just a tube. This is the tubule of a kidney, whatever. This lining, this is the wall, okay? This is the wall. This empty space, which is the actual opening of the tube, another name for it is lumen. So this is what I mean by lumen, okay? So for example, let's say, let's use this. This, you see this big duct here? This is the wall of the duct. The empty space in the middle is the lumen. So you need to know that. So again, this is the luminal side. This is the wall side, basically. And in the middle, you have the cholangiocyte. Cholangiocyte is basically the cell that lines the duct. So the cell of the liver is called hepatocyte. The cell of a muscle is called myocyte. The cell of the bile duct is called cholangiocyte. CHOLAN, this thing, cholangiocyte. Okay. So again, the ductal component of bile acid, bile, you just need to know two things. Surface CFTR secretes chloride into the lumen. Chloride is exchanged for bicarbonate. You need to know these two. If you're secreting ions into the lumen, these things are charged, right? Which means interstitium, connective tissue, basically the wall side, okay? So when you have more of these ions in the lumen, they attract water. If they attract water, like more water will go out, basically. You need to know that. This is a minor thing. Just need to know this part of this diagram. You need to know this part. Again, remember from that big picture thing we were talking about earlier, secretin, I think Riyad mentioned this, that secretin is release is done by S cells in response to acid. Therefore, the function of secretin will be to neutralize the acid. One of the mechanisms for secretin is to increase bicarbonate secretion of the duct, right? So remember this. So ions and water, right? So this ion is basically bicarbonate. This is the ion we're talking about. This is stimulated by secretin. So again, and now you need to know this mechanism. Secretin binds to its receptor on the surface. Secretin increases a bicarbonate secretion. So secretin binds to a surface receptor. This increases the luminal CFTR channel, which increases the chloride you're putting into the lumen. So secretin increases the chloride you're putting into the lumen. If you're putting more chloride into the lumen, more chloride is getting exchanged for bicarb. So more bicarb is going into the lumen. Okay? Does this make sense? CFTR transports chloride into the lumen as an exchange for bicarbonate. Yes. So again, chloride is put into the lumen, it's exchanged for bicarbonate. And this is promoted by secretin. Okay. And so the professor has basically then summarized for you. The result is more dilute. Dilute, why? Because you have more water here now. And more alkaline. Bialkaline, because you have more bicarbonate. And secretin would increase. They could actually bring this in a question. Which hormone, let me ask you, which hormone increases alkalinity of the bile? Bicarb. Which hormone? A hormone. Secretin. Yes. And I could ask you this in another way. So for example, by what mechanism by what mechanism is the bile made more alkaline? By what mechanism is bile made more alkaline? Cyclic AMP, okay, which increases chloride surface CFTR. Cyclic AMP, which increases surface CFTR. Yeah, so it increases chloride secretion into the loop. So to the geniuses, can you repeat the question? So I basically asked, what is the mechanism of secretin? Secretin acts by increasing cyclic AMP, which increases CFTR, which increases chloride. If there's more chloride, you're putting out more bicarb as well. I don't understand the question. Dilute of what? What do you mean? Yeah, so the result is the bile gets more alkaline. The bile gets more alkaline. And also gets more diluted because you're putting out more water. Yeah. Yeah, so chloride is the one getting reabsorbed. Yeah. Bicarb is the one getting secreted. Can I erase this in some way? Wait. Okay. Okay. So now we need to hurry up quickly, okay? So bile is moving down again. Bile is moving down these ducts. Bile is moving down these ducts. It reaches the sphincter of Oddi, which is the opening into the duodenum. This is closed normally. So bile goes back up and it stores itself into the gallbladder. Gallbladder has three functions, okay? It stores the bile, it concentrates the bile, and whenever you need the bile, it contracts to eject it. So those three functions: storage, concentration, ejection. This is telling you that that gallbladder concentrates bile. How does it do this? And this you need to know that gallbladder concentration is isotonic. You need to know this. Okay. Now, this graph is basically showing you this is the hours bile is spending in the gallbladder. Okay. So the gallbladder is absorbing water, so the volume is going down because it's absorbing water, but it's not absorbing bile, so the concentration of bile is going up slowly. Okay. This you don't, again, no need to concentrate much on this. You need to know that the way the gallbladder concentrates bile is it absorbs sodium, it absorbs chloride. If sodium is being absorbed, water basically follows sodium, right? So water is absorbed as well. Need to know that, that's it. And because sodium is positively charged and chloride is negatively charged, you're absorbing a positive charge and a negative charge. So this would be electroneutral. So basically the charge across the membrane is not changing because you're absorbing one positive, one negative. So you need to know basically two things. Gallbladder concentrates bile by what mechanism? Electroneutral sodium chloride absorption. Okay. This is telling you that once that gallbladder has stored the bile, eventually, I can't see the chat anymore. So. Okay, no problem. I'll just continue. And if any of you have a question, because I can't see the chat, just open your mics, okay? So again, this is basically showing you when you need the bile, the gallbladder will contract and release the bile into the duodenum. Again, a question for everyone. What hormone stimulates gallbladder contraction? What hormones? Yeah.
CCK.
CCK, yeah. I can see the chat now, is good. So you don't need to open your mics. CCK, good. So again, it's a negative feedback loop. Fat and cholecystokinin. So fat enters the small intestine, stimulates eye cells to release CCK. This CCK causes contraction of the gallbladder and relaxation of the sphincter of OD here. This causes bile secretion into the intestine to cause digestion. Bile is concentrated by electroneutral sodium chloride absorption. So you absorb sodium, you absorb chloride, water follows. That's it. You don't need to know much. You just need to know electroneutral sodium chloride absorption. It's one sodium, one chloride. So because it's a positive and a negative, you're not changing the charge across the membrane. So need to know that gallbladder concentrates bile. How does it do that? Electroneutral sodium chloride absorption. Okay. This is the enterohepatic circulation. I think we've focused on it quite a bit. You synthesize, you have around 2.5 grams of bile a day. And so you don't want the liver to synthesize it daily because that's too much work. So what you do is you absorb a lot of that from the ileum, again, the ileum, back into the liver. So the liver, so only about 600 milligrams of that original 2.5 grams gets excreted. Okay. So only about so out of those 2.5 grams of bile, only 600 gets excreted, and the 600 you can synthesize no problem. So this is the enterohepatic circulation. This you need to know again. Again, you need to know that most of it is in the ileum. You need to know that bacteria will deconjugate and dehydroxylate, which makes it more lipophilic. Then because it's more lipophilic, it can cross the membrane easily. So this is passive diffusion, okay? Again, so total is 2.5 grams. Yeah, you have a total of 2.5 grams of bile every day. But if you don't have the enterohepatic circulation, the liver would need to synthesize all of it back again, okay? So but that's too much work. So what you do is you absorb or you reabsorb from the colon, most of it, 95% of it, and then the liver only needs to make around 600. So the liver makes 600. The overall amount you have is 2.5. Okay. I think one of you asked me, does enterohepatic circulation need to have conjugated or deconjugated? Here. So this is important actually, because bacteria will deconjugate and dehydroxylate the primary bile acid to produce secondary bile acid. They will be lipid-philic or lipid soluble, and then they will be passively diffuse across the membrane. However, there will be some which are not deconjugated, which are conjugated. They will be absorbed. You need to know this as well. This is important. You need to know that this is active sodium transport, co-transport. So sodium brings bile acid with it by an apical sodium bile acid transporter. You need to know this point. So deconjugated bile acids are absorbed by passive diffusion. Conjugated bile acids are absorbed by co-transport with sodium. You need to know these 2 points. I'm moving a bit quicker because we have to finish really quickly. Again, this is basically a regulation. I told you, think about it like negative feedback. If you have less bile, let me get, okay. Yeah, I told you to basically think about it like negative feedback. If you have high bile, you don't need bile. So you inhibit 7-alpha hydroxylase and you increase BSEP, bile salt export protein. Remember that? Which is primary active transport. So if you have high bile, you don't need the bile. By negative feedback, you inhibit someone is asking me a question. What is BSEP? BSEP was this thing, bile salt export protein. And I told you this is the one thing you have to remember from this slide, that bile acid secretion is primary active transport via BSEP. Okay. So if you have high bile, you inhibit 7-alpha hydroxylase and you increase BSEP. If you have low bile, you need the bile, so you increase 7-alpha hydroxylase and you inhibit BSEP. Okay. I think again, we're repeating a lot of it now, so it should make sense. This is a case. If one of you can volunteer to open your mic, and I'll read the case and you explain what's going on. A 36-year-old woman had 75% of her ileum resected. Resected basically means removed, because of Crohn's disease. So her ileum was removed because of Crohn's disease. Her post-surgical management, basically they gave her B12, but she experienced diarrhea and steatorrhea. And why is this? So a woman had some sort of small intestine disease. They removed her ileum, but after they removed her ileum, she had steatorrhea and she needed B12 injections. Why?
May I answer?
Sorry?
Go ahead.
Because
Okay, so because the ileum was resected, isn't that where we deconjugate bile so we can have the enterohepatic circulation, right? So we can get back bile to the liver. So if we don't do that, then we'll secrete all the bile. So the liver will have to work more. So then if it works more, then we won't have proper emulsification of fat because we don't have the usual amount of bile we do. So she'll have steatorrhea, right?
Mm-hmm.
And diarrhea, essentially.
That's it. Good. And why B12? Does anyone know why B12? Why is B12 relevant here? B12 is absorbed in the ileum, yeah. What does B12 need to get absorbed? Intrinsic factor, yeah. So B12 needs intrinsic factor. And what synthesizes intrinsic factor?
Parietal cells.
Parietal cells, yes. Parietal cells secrete intrinsic factor. And so sometimes, I don't know if you guys had this question, but sometimes Dr. Peter likes to ask that intrinsic factor is the only essential component you need from the stomach. Okay.
It's in the slides.
Yeah. Okay, so you need to know that because he likes to ask it sometimes. Okay. Again, we discussed the action of CCK. CCK released by eye cells in response to fat in the duodenum. It has two actions: endocrine, which is not that much, and neurocrine, which is the major mechanism. CCK travels to the gallbladder and it causes contraction of the gallbladder via acetylcholine. You need to know the neurotransmitters, okay? You need to know neurotransmitters. So CCK causes contraction of the gallbladder and relaxation of the sphincter, okay? How the major mechanism is by a vagovagal reflex. Acetylcholine, again, acetylcholine. We can talk about intrinsic factor at the end, but this is important, so just concentrate here, okay? So again, acetylcholine causes contraction of the gallbladder. Nitric oxide and VIP cause relaxation of the sphincter. So CCK acts on the vagal reflex, which causes a vagovagal reflex. A vagal afferent means sensory, efferent means motor, right? So a vagal sensory nerve gets stimulated by CCK, causes acetylcholine release at the gallbladder, causing contraction, causes nitric oxide and VIP release at the sphincter, causing relaxation. This vagovagal reflex, aren't these neurotransmitters the same for the entire GIT? Yeah, but again, you need to know them. Doesn't mean they're not important, right? So nitric oxide and VIP dilate acetylcholine and substance P contract, right? Remember that? So you need to know these two. So acetylcholine causes contract, because I remember in our GI exam, this was a question. Okay, so why is it relaxed? Because the sphincter is basically preventing the bile. The bile is stored here. Okay, see the laser? The bile is stored here. It needs to come into the duodenum. But there's a sphincter here which is closed. You need to relax it. Okay, you relax it by nitric oxide and VIP. Intrinsic factor is what you need for B12 absorption. Just know this, okay? Intrinsic factor is needed for B12 absorption. For that case, B12 absorption occurs in the ileum. Okay, you took this in another lecture. This is why I'm not concentrating on it, because I have to finish quickly. Okay, so I'm sorry for not explaining it, but you know, I have limited time. Now, you need to know these two things, okay? So from this slide, no, CCK causes contraction of gallbladder, relaxation of the sphincter, okay? How does it do this? By acetylcholine release onto the gallbladder and nitric oxide and VIP release onto the sphincter. You need to know these two things. This is what we discussed previously. Now, this is just, this is the same for gastric secretion, okay? So let me give you an example. If when you smell food or when you taste food, it stimulates your parasympathetic system. Your parasympathetic system is your vagus nerve. And if your vagus nerve is stimulated, that causes acetylcholine release onto the gallbladder, causing contraction. Nitric oxide and VIP release onto the sphincter, causing relaxation. Okay. So again, this is important to know for the cephalic phase. They could ask you, for example, what is the major mechanism of the cephalic phase? The answer would be vagal outflow. Okay. The answer would be vagal outflow because it would increase acetylcholine release onto the gallbladder, VIP nitric oxide release onto the sphincter. In gastric, you have distension of the gastric, you have distension of the stomach, which causes a vagovagal reflex. If you remember from this, you will find in your gastric secretions lecture that distension of the stomach produces 5-hydroxytryptamine or serotonin. This causes a vagovagal reflex. This vagovagal reflex is not just in the stomach, but it's also in the gallbladder. It increases acetylcholine release onto the gallbladder, causing contraction. VIP release onto the sphincter, causing relaxation. So you need to know acetylcholine release, gallbladder, contraction, VIP NO onto the sphincter, causing relaxation. Okay. In the intestinal phase is because of fat digestion. Again, I told you once you have lipids in the duodenum, they secrete CCK from the eye cells. CCK has two mechanisms, endocrine, which is minor, neurocrine, which is the major mechanism. It causes a vagovagal reflex, causing acetylcholine release onto the gallbladder, causing contraction, same as before, causing VIP and NO release onto the sphincter, causing relaxation. Another mechanism, we discussed this again. We discussed it as a negative feedback loop. You have acid comes into the duodenum, stimulates S cells to release secretin. The secretin causes increased chloride release from the bile ducts, which cause increased bicarbonate secretion. If you remember that CFTR diagram, and the decrease in acid inhibits secretin. So it's basically a negative feedback. Absorption of bile acids in the distal part of the ileum. Absorption of bile acids in the distal part of the ileum. This basically refers to the enterohepatic circulation. I told you that once you have more bile acids, this will decrease 7-alpha hydroxylase, and this will increase BSEP, bile salt export protein, which was primary active transport. You need to know this, okay? So this was basically a summary slide. Yeah, I'll just quickly explain this. I'm sorry for the delay, but I'm sorry, okay? So now we discussed the different components of bile cholesterol, bile salts, and phospholipids, okay? If you have, so this cholesterol causes gallstones. Bile acids and phospholipids, the job of bile acids and phospholipids is to basically prevent the cholesterol from causing gallstones. Okay, so if you have a scenario where you have increase, okay, no problem. If you have a scenario where you have increased cholesterol or decreased bile acids or decreased phospholipids, this will cause precipitation of cholesterol. Remember, cholesterol is a lipid, right? So it likes to go out of solution. But the bile acids and phospholipids keep that cholesterol solubilized. Bile acids form micelles, which we discussed in detail. Phospholipids form vesicles. Okay, precipitation basically means when something goes out of solution. Okay, so cholesterol, once it is very high in concentration, it will come out of solution. If it comes out of solution, we said that because it's hydrophobic, it will like to aggregate to other cholesterol molecules. Once they aggregate together, this forms a gallstone. Okay, so you need to prevent this. Normally, bile acids form micelles, phospholipids form vesicles. These keep the cholesterol within a solubilized environment. Okay. Okay. Now, we discussed most of this. Okay. The second box, why we have gallstones? Because you have low bile acids. Okay, bile acids basically keep cholesterol solubilized, which increases, so bile salts and phospholipids, they keep cholesterol solubilized. If cholesterol increases or those two decrease, you will have gallstones, essentially, okay? Now, I'll get to this diagram in a minute. We'll finish in about, hopefully, again, I think 5 to 10 minutes, we can finish quickly. You need to know this diagram. You don't need to memorize the phases. You just need to know where you are in the diagram, okay? So so just to orient you guys, listen, I won't repeat this because we don't have time. Bile salts increase this way. Phospholipids are increasing here and cholesterol is increasing here. Phospholipids and bile salts keep cholesterol solubilized. If you have low bile salts or you have low phospholipids, this will cause cholesterol gallstones. Phase 1 is the normal, okay? This phase here of the diagram is normal. You have high bile salts, 80 to 100, you have high phospholipids, and you have low cholesterol, which basically means cholesterol has been solubilized, mostly in micelles, okay? Going to the second phase, going to the right of the diagram, bile salt concentration is decreasing. When bile salt concentration decreases, but phospholipid is high, so phospholipids form vesicles. So you will have vesicles and micelles, but you won't have gallstones here because cholesterol is low, phospholipid is high. Bile salt is low, but the high phospholipid is compensating. I'll repeat this one more time. First phase is normal, high bile salt, high phospholipid. These two keep cholesterol solubilized. Phase 2, bile salt is decreased, but you have high phospholipid, okay? The high phospholipid forms vesicles, which also solubilize cholesterol. The important point about this diagram is when you're moving to the high left, like this, when you're moving this way, you're increasing cholesterol concentration. So here you're increasing cholesterol. You're decreasing phospholipid. This causes some cholesterol crystals to form or gallstones, okay? These two phases, you have low phospholipid and you have high bile salt. If you have high bile salt and low phospholipid, you have low cholesterol here. Okay, so let me explain this one more time, sorry. Cholesterol is low here, okay? But phospholipid is not as high as it could be. Bile salt is high. So the main thing you have is micelles. However, there are some small vesicles of phospholipid, but cholesterol in those vesicles is saturated, which basically means it can precipitate. So cholesterol is slightly high here and it can precipitate. That's the main thing. Bile salt is high, so you have micelles. And that's what you need to know from this diagram. Phase 1, this part is normal. This part is no cholesterol gallstone formation because you have high phospholipids. When you're moving to the high left, you're getting cholesterol crystals or gallstones, okay? This is the last slide. Now, depending on where that gallstone is stuck, the patient will present to you differently, okay? So if the gallstone is stuck here, bile from the gallbladder can't get up, but bile coming from the liver can easily get up and go into the duodenum. So effect on duodenal delivery of bile salt is none. So it doesn't affect duodenal delivery of bile because the liver duct is okay. It's just that the outflow tract of the gallbladder is obstructed. So the gallbladder opening is obstructed, but the liver duct is okay. The pancreatic duct is fine. There's no gallstones here in number 1. Now, but the consequence of this would be because the bile in the gallbladder can't be released, it becomes like stale, okay? In medicine, you have a concept, basically, if you have an obstruction someplace, you have a buildup of fluid behind it, you will have infection in that fluid. So you will have cholecystitis and sludge in number 1. In number 2, the gallstone is stuck in the common duct. It's obstructing the liver, outflow of bile, and it's obstructing the gallbladder. So no bile is getting out here. So you will have cholecystitis and sludge because you have buildup of bile. Also, you have steatorrhea. Does the stuck fluid cause the inflammation? Yeah, because the fluid that is stuck becomes stale, and that causes growth of bacteria in it. That encourages growth of bacteria, which causes inflammation. Okay, that's why you have cholecystitis. If you're stuck in the common bile duct, it obstructs the liver outflow tract and it obstructs the gallbladder. Basically, bile is not getting out into the small intestine. So you have malabsorption of lipids and steatorrhea. And you have obstructive jaundice. I will explain jaundice at the end, okay? So just stick with me. I'll just explain it briefly so you guys get an idea of what jaundice is. If it's stuck here near the sphincter, the pancreatic duct is blocked as well, okay? So this will cause pancreatitis because the enzymes won't be able to get out into the small intestine. They will get activated within the pancreas and cause damage to the pancreas. So you will have pancreatitis. So depending on how the patient presents to you in an exam, maybe they could give you, for example, they could give you a guy who's having oil in his stool, who's having pain in this region, in the right epigastric region, going to the shoulder, and he's having pancreatitis. So where's the gallstone in this case? It would be in the sphincter of Oddi. Okay. Yeah, so exactly. So just try and ask yourself these questions in a way. So should I explain jaundice or should I just stop? It will take 2 minutes.
I say explain it.
Explain
Please.
it? Okay. I'll explain it very, very briefly. So just pay attention and I won't repeat this. So, okay. So you know that you have a red blood cell. Red blood cells are basically bags of hemoglobin. Red blood cells have a lifespan of about 120 days, okay? You know this from biochemistry. They release hemoglobin because once the red blood cell is old, it breaks up and it releases hemoglobin. Hemoglobin is converted into bilirubin, okay? Remember what bilirubin is? Does anyone remember what bilirubin is?
Yellow pigment.
Bile pigment, and it's yellow, exactly. Bilirubin goes to the liver where it's secreted into the bile. Okay? Now, imagine this, because you will take this. Now, imagine you have a lot of breakup of these red blood cells. If you have a lot of breakup of these red blood cells, you have a lot of release of hemoglobin. If you have a lot of release of hemoglobin, you have a lot of bilirubin. Increased bilirubin causes jaundice. Okay, so jaundice equals high bilirubin. Okay, remember this concept, because in jaundice, what do you have? You have the eye becomes yellow, the skin becomes yellow, and you remember that bilirubin is yellow. So jaundice is because of high bilirubin. If you have increased breakup of RBCs, you have high hemoglobin. That hemoglobin, if you have high hemoglobin, you have high bilirubin. High bilirubin causes jaundice. That's one scenario. The other scenario is, for example, you have the liver is not working properly. So bilirubin, hemoglobin is normal, bilirubin is normal, but bilirubin can't go into the liver, which means it builds up in the bloodstream, which causes jaundice. That's another scenario. The third scenario is that the liver is normal, but the bile duct is obstructed by a stone. So this step is bad. So the bile will build up in the liver and bilirubin will build up, causing jaundice. So those are three scenarios in which you have jaundice, okay? Remember this as a general concept. First year, second year, medical students, third year, whatever. RBCs release hemoglobin. Hemoglobin is converted into bilirubin. Bilirubin goes to the liver. Liver secretes bilirubin into the bile. If you have a problem with the RBCs, that will release hemoglobin. that will increase bilirubin. Increased bilirubin causes jaundice. That's one scenario. Okay. What causes increased breakup? Many things. So for example, if there's some genetic defect in the membrane of the red blood cell, that's one scenario. Second scenario is the red blood, there's some autoimmune disease. So your own body's immune system is attacking the red blood cells. You'll take this later on, but for now, just remember, if you have increased red blood cell breakup, you have increased hemoglobin. If you have increased hemoglobin, increased bilirubin. Okay. This increased bilirubin causes jaundice. This idea, one, I'll call this one. This is called pre-hepatic jaundice. Okay. Because it's happening before the liver. There's no problem with the liver, and it's happening before the liver. If you have a problem with the liver, like cirrhosis, I'll call this 2. This is called hepatic jaundice. Okay. If you have an obstruction in the bile duct because of a gallstone, this is 3. This is called post-hepatic jaundice. So you have pre-hepatic jaundice because of lysis of RBCs, hepatic jaundice because of cirrhosis, post-hepatic jaundice because of gallstones. And that's my lecture. Okay. Excellent. Did everyone, I hope that was a good lecture. It was my first time teaching you guys. So I'm sorry if I wasn't able to explain anything. Okay, thank you. Thank you. If you have any questions, you can email me, okay? I'll answer. My email is ashafqat@alfaisal.edu. Yeah, this thing. Wait, I emailed, wait, yeah, so ashafqat@alfaisal. Yeah, this is my email. So if you have any questions, email me, I'll reply, okay? And I'm sorry for taking a lot of time.